You're asking. Oh, good. Okay, so it sounds like the first person on the agenda is going to be Grace Weltman talking about the South Bay CEH, which you have to, and SPA 8 system updates. So, Grace, are you there?
Yes. Hi. Hi, everybody. Good afternoon. To make sure that I keep within a small amount of a window of time, whatever I cannot give an update on, you will receive an email about. Those there are a lot of things going on, but we wanted to focus on two things with the South Bay Coalition and homelessness. I want to talk about the design process that we are engaging in with the South Bay Cities Council of Governments and Changewell, who's a consultant working on these community designs. We wanted to go over that. And then I did want to give an update on the COC board. Did I do that? I don't know why I gave myself a thumbs up. Okay, COC board. Um, and give you an update on that. So first thing, as you remember, and then I'm glad I saw Ryan pop up on the screen because I'm going to refer to him in about 3 minutes or 5 minutes. Um, at our last South Bay Coalition meeting, we had Changewell present as they have been hired as consultants to help the new county department housing, homeless and housing services. Did I say it right? I think I did. Yes. I and what they wanted to do was hear from the community and have a really robust engagement process. And so each spa is engaging in some type of design session. So let me tell you about why we're coming together. We're working together to make the design session in Spa 8 happen, working very closely with the COG. It's been wonderful to have some consensus around some really key areas. But the purpose of these design sessions are to discuss ideas to achieve Measure A performance goals with an explicit focus on reducing racial and ethnic disparities experienced by people in the homeless system. Then also identifying structures and processes to support providers and cities who are contracting or who will be contracting with the county. And as many of you have already participated in some discussions, there are a lot of concerns about how this is going to work. How are these contracts going to be administered? What is going to be the payment process? All of those things. They want our input into that. And then designing a sustainable feedback mechanism. So, how do we, on an ongoing basis, continue to provide the new county department with our feedback, what we think? And I know we've been pushing to make sure that we don't want this to just be one listening session and then we're done. How are we going to do this on a regular basis? How are they going to keep us engaged? And so we have a timeline. After this, I think we will be releasing the notice for this process. So please read your emails. You'll get them from Addie, you'll get them from me, and you'll get them multiple times. But Wednesday, today, there will be a nomination process opening up. So we are asking people to nominate people you know or self-nominate to participate in a 2-day design session that's going to be held on October 15th and 16th. It's going to be 2 days. And what we're looking for, oh, Friday, September 5th will be the deadline. I wanted to give you those highlights. And that by mid-September, participants will be selected. So you'll know ahead of time, or the people that you nominate will know ahead of time. So the process in terms of who and what, we're going to get the nominations. We are looking at 75, right, Ryan? About 75 participants. And we want a cross section of people representing a diverse group of, we're going to have people who have lived experience, agencies, cities, uh, there's a whole slew of categories that you'll see. And we also want to make sure we're representing different parts of the system. So youth, families, housing, all of those. So we want to make sure that you're aware, and we're encouraging people to just nominate others, and it really is a commitment because it is 2 days, but it's also gonna 2 days is a long time for a lot of us, right? 2 full days. We are trying to secure a location. And in the process, know that once the design session is done, the data, all the spas are doing this, all the regions are doing this. We are going to have another session representing the southern portion of the county, so spas 5 through 8, if I'm correct with that. So that's in a nutshell what we're trying to do with that. And Ryan is with Changewell. He's a consultant. Many of you know Ryan Hurley. Would you like to add to anything that I said or didn't say?
Yeah, no, thanks, Grace. Hi, everyone. I think you did a good job of summarizing kind of the process. So you've been hearing about how the Board of Supervisors called for community engagement to help inform standing up the new Department of Homeless Services and Housing. As part of that engagement process in October, this is going to be the first opportunity to really sit down, roll up your sleeves, and provide not just feedback, but provide solutions in real time. And so I want to really differentiate kind of what everyone is used to in terms of listening sessions, in terms of town halls. In October, that's not what we're talking about. We're talking about 2 full days, and I recognize, just like Grace said, it is a very big lift, and not everyone can make that commitment. But it's really important because the 2 days, by the end of it, is going to come up with a set of recommendations, and not just recommendations in a very general sense, but very specific designs for issues within the system, within the areas that Grace outlined that are called for in the board motion. So a listening session, yes, you can provide feedback on what's not working, but you oftentimes are left not wanting more, right? Because you don't actually get into problem solving. That's where this is going to be different. And so I think it's going to be very important to think about who makes sense to participate representing the various groups that you may represent. And please send those nominations. And as Grace said, this will be the beginning of a multi-phased engagement process. So after October, there will be then in November a session where different spas can come together and share their recommendations and find out where there's commonality. Because at the end of the day, by the end of this process, the Board of Supervisors has asked for one uniform set of recommendations. So I'll stop there. And Addie, do you want to jump in and add anything?
No, I think you all have covered it all, and as we work with the in collaboration with South Bay Coalition to End Homelessness and the South Bay City Council of Government, I do want to emphasize the need for diverse voices, right, and diverse folks at the table. Not just like, and there's nothing wrong with, the same game players and folks that have done this work and continue to show up in this community. However, it's important that we're hearing from multiple lenses, multiple perspectives. And oftentimes, a lot of the cities that are on this call will know that you don't often get invited to these tables. And so I would encourage you all to prioritize this, to think about folks in your city that could really add insight or guidance to the process and the goals that Changewell and well, really the county are hoping to implement. So, like Grace and Ryan said, you'll be receiving communication from Grace, from him, and for the cities myself, regarding folks who you think would be great partners in this process. So, be on the lookout. It is a lot of information, but most of you all have my information, so feel free to reach out to me if something isn't clear or if you want additional information or context. I'm happy to provide it. But I do encourage you all to start thinking of, even if it's yourself, because you can nominate yourself as well, of people in your cities, communities, organizations, agencies that would be ideal candidates for this opportunity.
Yeah. Oh, and thank you, Addie. And I was going to add, we really want people to roll up their sleeves, and we have a lot to say about the system, but really, what solutions can we craft together so that we can make really robust recommendations to the county. So thank you for you know, Addie, thank you for adding that and making sure that we emphasize the diversity needed in this session, in these sessions that are coming up. So you'll get this later today from us. You'll get a notice from somewhere, right? Right. Um, we have it ready to go. I have my second update. Wanted to talk about, as you know, um, the LACOC has been waiting for HUD to release a notice of funding opportunities, a NOFO. Initially, we weren't sure we are going to get anything, but any day now it's supposed to drop. So we are expecting that there will be an application for funding from HUD, but things are changing. But we don't know what those changes are going to look like. Meaning, we don't know what will be prioritized and how. And so we will be ready to do that. One of the things that I'm fairly new to the COC board, but because we've been participating in a lot of other discussions or with other groups, we know that 2026 is not going to be a good year for funding overall across all the systems. So I've been pushing at the LACOC board level to really make sure that we do begin having these contingency planning discussions. Because if many of you remember last year, we were all calling, you guys were all calling, not all, but a lot of you were calling because we were notified pretty late that there were going to be cuts to the system. And so one of the things that I'm pushing for is for us to continue to start having those discussions. And so that's something that I would like to agenda at the next coalition meeting. But I'm sure this is an interest of the COG, so maybe we could do this jointly, Addie. And just thinking through, because I just got something from somebody, it hasn't been released, but the other cuts in the other system um, from the federal government. So, again, 2026. So be on the lookout for that. Not just we want the NOFO to come out. From my understanding, we probably won't be funded based on the way funding has been cut at the HUD level. At the NOFO level, we have been funded at, right? So I think Ryan's an expert in there too. So he could add or subtract anything that I might have said, but just wanted to let you know. And as soon as the NOFO is released, I will send an email out to everybody and let them know. Any questions on the two pieces that I covered?
Yeah, this is Philip of Grace. I have a quick question. So
Yeah,
regarding the HUD funding, do we have an idea? I mean, obviously we don't want any more homelessness, right? I mean, so
right.
whether it, I'm thinking specifically as it relates to our seniors and whatnot, do we have a, you know, idea where those impacts may, sh manifest itself relative to the, effective population, if you will?
Yeah, well, what's interesting, not interesting, what's troublesome is that I think that I know permanent supportive housing is not going to be prioritized. And they have some language from the Trump administration. They have language in there about street outreach and wide temporary housing. But the fact that they will fund probably permanent supportive housing, but we don't know if it's going to be at the top of the priority list because it had been in the HUD guidelines. So for instance, hopefully this makes sense. If it's not prioritized, it might get bumped into the second tier, which makes us more competitive with other regions and doesn't guarantee it. So we don't know yet. And and not knowing has made me think, well, is there room to talk about the match or what can we do? I mean, we just don't know what they're going to prioritize. And I don't know, Ryan, did I miss something about the priorities? That might change.
Sure, you're putting me on the spot.
I'm sorry,
I'm
Ryan.
not here at the meeting in this capacity, but I can wearing my former hat where I was a consultant to LASA on the Continuum of Care program. I can just speak real quick. There's a lot of anxiety, I would say, that's palpable in terms of what's coming, just because of a lot of the shifts we've seen in rhetoric, if not in policy as well. And that said, we don't know what the competition will hold, and what Grace is talking about is just one pot of funding from HUD. The COC program, NOFO, doesn't touch CDBG, doesn't touch ESG. Other programs from HUD that are of importance to probably a lot of people on this in this meeting. So we'll have to wait and see what's actually in the notice. But what Grace is really talking about is there's going to be a shift in terms of new funding that's available for the competition. And normally in past years, the emphasis has been on permanent housing. For this administration, it seems like there's going to be some backtracking and have emphasis more in street outreach and transitional housing models and service interventions that the federal government hasn't funded for a number of years. But until the funding notice comes out, we don't actually know.
And I think we should look at this holistically, like many of the cities have used their CDBG funding to support some of the work that you're doing. And I know that that could be an issue. We also have been told by the county that Measure A revenues are not coming in as anticipated. So if we experience a reduction from Measure A, we're looking at this. I'm looking at this holistically for all of us to just think through as a region. How do we come together and work with each other to make sure that we do some planning or forward thinking around this?
Yeah, and I certainly appreciate that. And because then I start thinking about Measure A funding, and that's still, in its infancy, if you will.
Yeah.
But if there's an opportunity, we've had multiple discussions at the COG, what are we doing with Measure A funding? So, if there's an opportunity where we see a gap, and we could fill that gap potentially with Measure A funding, again, make sure everything, meets the requirements or whatnot. That's certainly something I would think we'd want to explore.
And
So I
remember, the
appreciate that.
city and the county have to match whatever HUD gives us. There's a matching component to that. So, yeah, and I think the more we talk about this, the more we're ready to advocate for what we need. So,
Okay,
thank
perfect.
you, Bill, for your question.
No, appreciate it. Thank
And
you.
Shannon said in the comments that they've said they will be prioritizing recovery, encampments, and workforce development.
Okay, perfect. So thank you very much for that. Moving on, item 3, hopefully I'm track. Presentation on LA County mental health resources and overview and tutorial. Aubrey, are you on?
Yeah, good afternoon, everyone. I'm Aubrey Lovelace from DMH. I'm actually going to have one of my colleagues, Dan Mansfield, launch us off in our presentation today.
Hey everybody, I'm gonna try to share a PowerPoint. Let's see how this goes. All right, and we all see that.
You're up,
Cool.
You're good.
Yes.
All right. Lots of slides. Going to really try to rush through this, and we will get you guys a copy of the slides so that you have all of the information. But if you take nothing away from this, other than one thing, let it be this. DMH has universalized our referral process into the system. So you no longer need to know what program, what clinic, what building, what phone number, what email address, what website to go to find the right service for a person you are trying to refer. All you need to have is this QR code or this link. It is an online form that changes based on what you are answering and goes to a centralized triage team that determines what the most appropriate service for the person is, facilitates that referral getting there. It has feedback loops to make sure that things are being followed up on. So again, just really, this is sort of the whole presentation. I'm going to give you a lot more information about where things go after you submit things here. But this will suffice moving forwards for any county Department of Mental Health needs. If you use this link, you will get somebody at least referred to services. Cannot always promise that linkage will be successful because people have the opportunity to say that they're not interested. When you go to this website and the link on the slides that I'll be sharing with you, there is a training on using The tool, I'm not going to play it here. It's very simple. Really just walks you through what the website looks like, how to submit things. Really, it is all very self-explanatory when you go to it. After you have submitted a referral, you will get an email confirmation within a day that includes a tracking number, includes information about the program that the person was referred to so that you can follow up directly with that program if you want to provide information. Not all programs are able to reach out to the referring party. There are some differences based on privacy law with focal populations of programs. It gets kind of complicated, but they are not all allowed to assertively reach out to the referring party. They will all assertively reach out to the person referred. But if you want to reach out to the program, you can always do that with the information you've been provided. You can also reply to the email that you get, and that centralized tracking team, triage team, will look into where the referral currently stands with the program it has been referred to. So there are a few different ways to follow up here and sort of keep the system accountable after you've submitted a referral. Again, can't promise you that submitting a referral means that the person you're referring is absolutely going to get services, but it means that they will get referred to the appropriate program. People just have the right to say no to many of these programs. So let's talk about where referrals go after you submit them on that website. So this is a grossly oversimplified look at the county mental health system. We have treatment, longitudinal, ongoing treatment intended to help people progress in their recovery. And then we have crisis services, right? Things that happen in the moment, really designed to overcome something that is really unsafe right now. These are generally pretty separate services. Going to go through both of them as best I can here. Some of our treatment services have crisis services built in, but our crisis services generally do not have ongoing treatment services built in. So first, we're going to go through what the various treatment levels of care are. Our lowest level of care is outpatient services. Again, I'm going to move pretty quickly here because we've got a lot to get through. Outpatient services are clinic-based, like any of us going to a doctor's office, same thing, right? There is a building that people go to meet with a therapist, meet with a doctor. They can provide therapy, psychiatry, medication management. We have both clinics that are operated directly by DMH, say DMH on the door. We then have contracted providers providing exactly the same services, D.D. Hirsch, specific clinics, Sycamores, these kinds of things. These services are for anybody that is eligible for Medi-Cal and has a fairly severe mental illness. So you have to have a functional impairment in order to qualify for DMH provided services. Functional impairment meaning you are sick enough that it is impacting the way that you function in your life, right? So anybody that is homeless, anybody that is on the street, has their functioning impaired, should qualify for these services. These are some of the diagnoses that people have that get these services, but there are others as well. We access these, again, by the QR code. There are some other ways you can do it. Really encourage you to just use the QR code. Everything else here is far, far more work. When you do get linked to, when you or really the person you are referring gets linked to an outpatient clinic, this lowest level of care, when they first get contacted, they're going to get screened. And I have all 14 screening questions here in case you're curious or in case you want to prepare somebody for that you are referring. And what happens here is the department determining whether this is somebody eligible for DMH services or whether their Medi-Cal managed care provider is required to provide them with services. So if there's not as severe of an illness or not as much impairment, they will be referred over to the managed care provider. If it is pretty severe, it'll stay with DMH. Not going to go through all these questions, but they are basically asking about somebody's history, about how bad things currently are. I share them when we do this presentation because we know that people tend to minimize what they're going through in early conversations with mental health providers. So if you are making a referral and you really want to ensure that somebody's going to get the appropriate service, sometimes it helps to coach them through the screening process, help make sure that they're answering these accurately and not downplaying what's going on in their life. Clinics are, like I said, actual locations, right? So people have to be able to get to them. Sometimes that's not going to work for a population of people experiencing homelessness, right? They are not always able to transport themselves where they need to go. And our clinics don't always have crisis response capacity. So if somebody needs a higher level of care, and this will be determined by the information you provide on that website at the QR code, they'll get referred to one of our more intensive services. Again, going to move through most of these pretty quickly. But FSP, full service partnership, is the sort of the workhorse of the department for intensive level need. These are field-based teams with low staff to client ratio that have crisis capacity. They can respond in the middle of the night when they need to. Really, they are doing whatever they need to support somebody's recovery, right? All the same stuff clinics can do, but they will do it in the field. They then do a lot more case management. They have funds they can spend when necessary to get people food, shelter, clothing, whatever it might be. FSPs are designed to be able to meet people's needs. This is for people that have a more severe illness than would be treated at a clinic. So schizophrenia, schizoaffective disorder, really, really impaired functioning. And there are some stricter criteria here. So either need to be experiencing homelessness, need to be justice involved, they've been arrested before, or really need to have been hospitalized multiple times. Our folks that are experiencing homelessness should qualify for FSP, but if their illness is not that severe and what you're filling out on that website seems to indicate that they have a good level of functioning, it will go to clinics. If you want it to go to this more field capable team, you need to articulate why that is going to be necessary when you're filling out that form. Again, QR code. If you really love filling out forms, you can find their referral form on their website. And I think you still have to fax it, actually. Really encourage you to just use the QR code. It is so much easier. We really encourage people referring when a client gets linked to an FSP to facilitate that initial meeting. So if you know this person, be there, coordinate with the FSP, make that introduction so that there's a better chance that it's going to stick, that the person's going to say yes to services. And it's important to note that, like, ultimately, people being referred have to consent to these services, right? They're going to be asked if they want them. They need to say yes. They need to sign some consent forms. When FSP alone is not going to be enough to serve somebody, right? When we're looking at really severe illness, really severe impairment, we get into these higher levels of field-based services. AOT and CARE are very similar. They are court-involved programs that really function a lot like FSP, but have court oversight. You have basically what it boils down to is you have a judge telling a client that they need to engage in treatment in both cases, both AOT and CARE. There are some pretty strict criteria for who can be enrolled in each of these programs. Not going to spend time on it because now that we have this universal entry tool, it doesn't matter as much anymore. You don't have to do that work. You don't have to fill out this form and make sure you're meeting that criteria. Our triage team is going to determine whether or not your case is meeting that criteria. Again, court involvement, but nothing really happens if somebody doesn't comply with that court order. The judge can order a hospitalization. There is certainly not incarceration. There is not long-term hospitalization in either of these programs, AOT or CARE. Both are intended to be voluntary programs ultimately. A judge can order this, but the person needs to engage. Again, you will get all these slides. I know I'm moving through this very quickly, but promise you I am hitting the key points here. Again, all of these programs, QR code, I'm going to keep hammering at this because it is the most useful thing. There are a lot of eligibility criteria for CARE. All right, and then you get to home, which is where Aubrey and I and Elizabeth and Ramona, who are on the call today, work. We are the highest level of care in the mental health system in LA County for people experiencing homelessness and a severe mental illness. So we can do everything all of those other programs can do. We really take a homeless services approach to our reach where we are pretty relentless. We are going to keep coming. We understand what it takes to build a relationship with somebody, to get them to engage in treatment, to take medication. And then when somebody is so ill that really they can't engage in those services, and really that's our focus, is people who are so ill that they lack capacity, they lack insight, they lack judgment. Those are symptoms of severe mental illnesses. When we are trying to help somebody that is that severely ill, we can pursue hospitalization and conservatorship, which is a long-term hospitalization, or really a court saying, you're not very good at making decisions about your mental health care. We are going to give that power to somebody else for a year. And that person can decide whether or not you are in treatment, whether or not you are in the hospital, where you live, that sort of thing. So for us to take a case, for home to take a case, there have to have been failures of the system at lower levels of care in either the mental health system or the homeless services system, right? So other people have to have tried. And that's because we are relatively a pretty small program, right? We're at sort of the top of this pyramid of care, where like FSP has thousands and thousands of available treatment slots. We can only serve about 2,000 people countywide per year. So we need to ensure that anybody that can be served at a lower level of care is served at one of those lower levels of care. Once we get involved, we are doing everything we possibly can, as I said. And when that fails, we pursue hospitalization in a way that is different from the traditional use of hospitals. So we are not responding in crises. We actually don't have crisis response because of the intensity of the other services we need to provide. When we hospitalize somebody, it's more like if one of us had carpal tunnel and needed a surgery to release that, right? We would not just show up to the emergency room for that surgery. We would plan that out, right? We would schedule it. So we see hospitalization as a procedure like that, where we're going to exhaust everything we can possibly do prior to hospitalization, prior to restrictive interventions. And then we're going to plan for hospitalization that is going to be effective, right? I imagine many of us have been frustrated by very brief hospitalizations for people experiencing homelessness, for people in crisis, that don't result in real change. People wind up back on the streets. When we hospitalize somebody, we're really trying to ensure that that doesn't happen. With specific aims in mind, we are really partnering with these facilities, visiting, coordinating. When one hospitalization alone isn't enough to stabilize somebody, we can then pursue that conservatorship, right? So the judge saying somebody doesn't have the power anymore to make decisions. And this is different from the traditional way of pursuing this, which relied on hospitals. Hospitals see people inside and cleaned up and on medication and not at their worst on the street where we wind up seeing them. So our psychiatrists that are out on the streets can initiate these petitions when necessary, and we can pursue this. It is a very small portion of what we do. As I said, we serve about 2,000 people a year, 2,000 to 2,500. We only pursue hospitalization in a couple hundred. We only pursue conservatorship in about 100. So it's about 5% that we pursue conservatorship on, about 10% that we pursue hospitalization. Everything else is voluntary, unrestricted. When we do hospitalize people, though, it is effective. Only 10% of the time when we hospitalize somebody do they return to the street. And even then, we're not giving up. We're going to continue to serve them. We are likely going to hospitalize them again, but we will continue to try. We also, my slides are a little wonky here. When we pursue hospitalization, we are not relying on law enforcement to do that. We do this ourselves. So the department changed some rules a few years back that had previously prohibited mental health staff from restraining anybody who needed a hospitalization, and we now will physically restrain people when it is necessary. Again, it is always a last resort, but I think many people in the community have been frustrated by calling crisis teams or calling law enforcement and an inability to get somebody onto a gurney into the hospital, and we are able to ensure that that happens by doing it ourselves. So things to just know about us, sort of our limitations. I think we are really great, but we're certainly not perfect. We need to be able to find the person. So we sometimes get referrals for like the guy in the blue shirt on the corner of such and such. Like, if he's not there tomorrow when my team goes out there, we're not going to be able to do anything, right? So we need to know where this person is, or you need to be able to show us where this person is. Again, that lack of success at lower levels of care has to be articulated. We don't have crisis response capacity. We are slow. It takes a really long time to build a relationship with somebody so that they will let you give them medication on the street and ultimately give them an injection on the street, right? So there's often frustration that things are taking a long time. That is by design. It is necessary. I mean, I think of it this way. I am hard pressed to imagine anybody that I would let walk up to me on the street and give me an injection of an antipsychotic medication that sits in little plastic beads in my muscle that are slowly going to dissolve over a month, right? Like that's what we are trying to convince people to do. It takes time to build enough trust to do that, especially with somebody with a severe mental illness. And we are always trying to avoid hospitalization and conservatorship. Again, refer to us with the QR code. You can Google DMH Home and find more information about the program. We do have a referral form and email address, but really at this point, we are asking everybody to use the QR code. So that brings us through all of the treatment options. That there are others that the QR code can lead to. These are the primary ones. And now I want to talk a bit about crisis services. I think I have a bit more time. So just broadly, there can be some misconception about what a crisis is, right? And it can be a pretty general definition, right? Anytime somebody's putting themselves or other people at risk, right? A problem that cannot be resolved with the available resources due to mental health or substance use. It is great to be able to call real crisis responders, but there are things that any of us can do. There is a model called mental health first aid that I would encourage anybody who's interested to try to find a training in. It is generally free, but pretty simply, you try to determine what's going on, you listen, you provide information, and you encourage people to try to get help or help themselves. I know that that is not always sufficient, right? But I think it can be hard sometimes for us to just not know what to do at all other than like call 911, and many of us don't want to do that generally. So mental health first aid is a really great sort of foundation in like, how do I figure out what's going on and figure out what I can do to help? When you do need to call somebody, this is the county's guide for who to call when. So 211, general resources, 988, suicide hotline, which will link to the DMH 24/7 access line when necessary, but you can call our access line directly to get a DMH crisis team. 911 when things are really seriously dangerous in the moment, right? If somebody is about to die, about to hurt themselves in some significant way imminently, no DMH crisis team is going to be able to respond quickly enough or manage that when they get there. So 911 is the appropriate call in those cases. When crisis responders get there, they're going to engage the person in a crisis, they're going to try to figure out what's going on, and then they're going to develop a safety plan. Sometimes that means hospitalization. They're going to try to see if it can avoid hospitalization. Safety planning without a hospitalization is a pretty robust and structured process, right? So it is helping somebody recognize what's going on, what they can do to help themselves, and really reduce risk in some other significant ways, like taking away weapons or things people can use to hurt themselves, making sure that they have the resources that they need to help themselves. So when crisis teams come out, whether it is DMH or a DMH and law enforcement co-response team, right? This is what they are aiming to do. They want to avoid hospitalization, if at all possible. So they are always trying a safety plan to connect people to other resources. When that doesn't work is when we start to look at 5150s. And these are involuntary hospitalizations that can legally occur when somebody's a danger to themselves, others, are gravely disabled. And grave disability means so ill that you can't provide for your food, shelter, clothing because of that illness. So that's really Home's population, the people that we serve. And again, right, I think the hospitalization is often looked at as the answer to a problem. It really needs to be a last resort. We are taking away somebody's physical freedom, their civil liberties, often having to physically restrain them. Medication will be forced into them at the hospital. It is a big deal. It is as big a deal in many ways as arresting somebody, right? So it is going to be avoided if at all possible. And then, even if it's appropriate, sometimes it's not feasible, right? And this is why we see law enforcement disengage sometimes, because they're not going to be able to help somebody safely. The same thing can happen with a mental health crisis team, right? if somebody cannot be approached safely, can't get on a gurney, they might not be able to get to the hospital, even though that would be what is necessary or appropriate. So it's important to know, like, there's no, I wish we had magic wands to teleport people to the hospital, but it can be pretty complicated and pretty dangerous to try to get somebody there. So it's important to note it doesn't always work. Once somebody does get to a hospital, there is a very large section of law that determines how long they can be held and what the process for that is. This chart is here and you will get it. But the initial hold is only 3 days, and to extend anywhere beyond that, doctors need to continue to prove that it's necessary. Going to try to rush through some of these crisis services. DMH has a few. Our alternative crisis response, the backbone of it is PMRT. These are clinicians that come out, evaluate, do everything I just talked about doing. They will hospitalize when necessary. This is for anybody in the county. Yes, thank you, Aubrey. Really, anybody in the county, does not matter what your insurance coverage is. If you or I tonight were in a crisis, somebody in our life could call this number, and DMH clinicians would come out and evaluate. They will facilitate the hospitalization if necessary. These are dispatched from our, I got a little ahead of myself there, from our 24/7 helpline, that 800 number. If you call the suicide hotline instead, and this is necessary, they will link to our hotline. They'll connect the call. Again, not going to be able to handle everything, right? I try to set realistic expectations. So when there is imminent danger, when there has already been a physical injury, when weapons are involved, law enforcement is probably the more appropriate response, and the dispatcher for PMRT will inform you of that. Response times can vary. You might have seen on a slide a couple ago, like, we only have, a few dozen crisis teams for the county, compared to law enforcement. It's really not very much. So our response time can vary. And whoever is calling needs to be present when the team arrives. This, unlike law enforcement, they're not gonna go do a welfare check for somebody. Somebody needs to be there. We then have our law enforcement teams. These are clinicians paired with the local law enforcement agency. Most of the law enforcement agencies in the county have one of these. I know there are many in the South Bay. They go by various names. They are operating differently based on how the law enforcement agency wants to operate them. Generally, they are dispatched by calling 911 in that area, and then the department determining whether or not they want to send one of these teams, whether or not one of these teams is available. You can try to request one, but again, it's ultimately up to the department. It's important to note that when one of these teams responds, this is a law enforcement response with a clinician, right? So it's likely that handcuffs are going to be used, and we try to make sure that people know that, because we don't want anybody making promises to people they are trying to help that, that they won't be put in handcuffs, that they won't be arrested. If one of these teams is responding, it's very likely that handcuffs are going to be used. We then have some urgent care centers. Won't go into this too deeply. I know that there are 1 or 2 in the South Bay, 24-hour walk-in centers where you can get assessment, medication. They can hold people for a day on a 5150 if they need to. There is a list of them here that you get when we share the slides with you guys. There's also a website that lists them all out in case that ever gets updated. Need to be able to get there, which can sometimes be a limiting factor for some people. And it's important to note that if you walk into one of these and say something that prompts them to think you are really dangerous to yourself or other people, they can hold you. They can involuntarily hold you and ultimately transfer you to a hospital if that's necessary. So we like to make sure people know that when they're encouraging people to walk in. Again, don't want any services misrepresented to the people being served. Lastly, we have hospitals. We all know what hospitals are. I mentioned them here because there is a significant difference between hospitals that have mental health services on site and those that don't. Only some hospitals in the county are designated to involuntarily treat people. If you walk into an ER and need involuntary treatment, it is going to be much quicker, easier if it is at a hospital that is able to do that, rather than at a hospital that needs to transfer you to another hospital for that. And so, like, to provide this list so that people know. But really, any ER, if you walk in and are reporting mental health symptoms and need help, they will figure out how to help you. Again, most of the treatment at least, can be accessed using this QR code. Really encourage you to use this. If it is a crisis, do not fill out this form. Call one of those numbers, right? Call 211-988, our 24/7 helpline, or 911 to get services for people. Our 24/7 helpline can be helpful in other ways, can provide other information about other services. But really, if you are looking to refer somebody for mental health services and ensure that that referral is trackable and that you get some information about that, the universal entry referral is the way to do that. I am happy to answer any questions you might have.
Hey Dan, do you mind putting the QR code back on just so I can get a snapshot and share it?
Yeah, give me 1 second.
Laura, you had a question? You had hands up?
Yeah, thank you. Great presentation, very detailed. Can't wait to get a copy of it. I'm down in the harbor area in San Pedro, and down here, part of CD 15 and SPA 8, we have a 24-hour, the Circle team. I didn't see it mentioned in here anywhere, which deals with people having some type of psychotic break or some mental health issue out on the street. And the way we trigger them is we have to call, because part of LA City, ask 877 ask LAPD. They determine then the operator whether it's an emergency for the Circle team or if it needs law enforcement because it's dangerous situation. So they determine that. They have 3 shifts, 8 hours each. What I'm wondering is, and then if they pick somebody up at their office, they have what they call a decompression room and kind of, talk with them and stuff. Have you partnered? Because the Circle team's also in Venice and Hollywood and other
Yeah,
areas.
so Circle is a city administered program. It's not an LA County DMH program. So certainly, like they refer to DMH all the time. They will call PMRT when necessary.
Okay.
But Circle is an alternative to law enforcement program operated by the city. Our programs are mental health programs operated by the county.
Yours
So,
is strictly county.
Yeah.
I
Would
hate
operate
this
in
jurisdictional
city
stuff.
areas, right? LA County DMH provides services in every city in LA County, all 88 cities. But Circle is a contracted service administered by the city of Los Angeles.
So they would never contact you. They would have to go through the city, is what you're saying.
They refer to us all the time.
Oh, they do?
We get referrals from Circle all
Okay.
the time. Yeah.
Okay, great. Thank
We are
you.
just not embedded with them. We don't control them. So, choosing to ask for them is separate from anything that we do.
Okay. Appreciate great presentation. Thank you.
Yeah.
Sarah, you have your hand up? Sorry.
Yes, thank you. I think this is more of a question for the COG. Could we get some numbers from the agency about FSP and home and how many are in each of our, because we've been referring a couple of times and we don't see SP8 out there. We don't see any clinicians or we don't see the home team. So if we can kind of get some numbers, I just wanted to see if that was possible to get maybe at our next meeting.
Yeah. Yes, thank you, Sarah. I will work with DMH to follow up on the services as well as the number. I know we got a request from a different city as well I know you said, Dan, that there are some like hospitals or services that are specific to the South Bay. So maybe having a better, I think, or more accessible catalog of those resources as well. Thanks, Sarah. I'll make note of that.
Hey, Paul, you've got your hand up? Paul, you're on mute.
Yeah, I'm sorry. Thank you for your presentation. How will Senate Bill 43 affect your efforts or impact your efforts?
Yeah, so SB 43 expands the definition of grave disability to include physical health symptoms, to include substance use as a cause for the grave disability, and allows for involuntary treatment for substance use disorders and grave disability caused by substance use disorders. The department, the county, in our department in collaboration with the Department of Health Services and public health are extensively planning for implementing that next year. It is not going to change very much about the way that these services are delivered. It will expand the scope when and where necessary. what the data coming out of other counties that have implemented SB 43 looks like right now is that the number of involuntary holds has not actually increased, because a large part of what SB 43 is really doing is bringing the language of the law in line with how it has been used. Nobody is not sending somebody to the hospital when they need to go because of substance use, right? Like nobody's saying like, I can't hospitalize this guy because he's drunk. So it has really already been functioning in that way. What will be different is you can continue to be held for substance use treatment. Unfortunately, there are no involuntary substance abuse treatment programs. Remains to be seen whether there will be, but currently there is an effort to link people to voluntary services. There are also questions about whether involuntary substance abuse treatment is actually effective. So will not, sorry for the long-winded answer, will not change the services we provide. Scope might be expanded, but not expecting significant changes.
Thank you. Catherine, you have your hands up?
Yeah, hi everybody. And yes, thank you very much. I mean, this is a lot of information to digest, Dan. My question is, when the case managers do a referral, okay, and they're waiting for response, are you going to let them know if their client isn't going to be seen by DMH or outreached by DMH? Or are you going to leave them out there trying to figure it out?
So federal privacy law prohibits us from sharing information.
Okay.
I understand how frustrating that is. We would love to be able to tell you when something's not working. Would love even more to be able to tell you when things are working, right? Because we do a lot of really great work that we would love to celebrate. It is a federal law. We cannot
I
share
get that. I get that. I mean, but we've got to figure out a way to at least sneak a piece of information that says, okay, we got him. Okay. Or, oh, no, we don't. So that our case managers know what they're doing out there, because they're flying blind when they've got what they consider to be a service-resistant, high-risk client out there that they can't help, and they need you. And for whatever reason, your system is saying, not yet, not now. So there's got to be a way to
So
get
there is a tracking number provided, like basic information that does not violate federal law can be provided. Sometimes that will include whether or not somebody has been linked or not. But there's no sneaking information around a federal law. Like we are bound to protect people's privacy. I understand how frustrating it is. We think it is frustrating too.
I'm just trying to help my case managers out there. Okay, because I feel for them when they can't get this info.
Yeah.
So Dan, back to that question.
We have to follow federal law. Yeah.
If you have a tracking number, I would assume the tracking number would suggest where somebody is in the process. Is that fair?
We can see that internally. Again, some information may be able to be provided based on specific type of program or where it is at in the process, but I cannot make the promise that we will be able to tell you definitively whether somebody is actually enrolled in a program, whether they have refused. Again, like I understand how, like, I am annoyed that I have to give you this answer. I get it. It is incredibly frustrating. We cannot break federal law.
No, I wasn't suggesting. I was just wondering if the tracking mechanism in and of itself might be an opportunity to just say where somebody is in the process, if you will, without giving information explicitly that would violate federal laws. I mean, obviously, we all got to be compliant with the laws. That's a given, right?
Yeah, we will share what we can. Unfortunately, with the way that some programs operate, by statute often, like we are not able to say whether somebody has refused services or whether somebody has enrolled in services. We may be able sometimes to say whether a referral is still open, whether it's closed, that sort of thing. But that is going to vary based on the program, and I can't make any promises. I encourage you to follow up with the tracking number, because whatever information that can be provided to you will be.
That's the mechanism.
I just want to jump into, I think the other piece for your case managers who are out there in the field and things like that, if they're the ones who've submitted the referral, so they're the referring entity on the referral, they also, like, especially for home, and the same would be for an FSP team, like, we're obligated to call the referring entity and say, hey, I got your referral for Steve. Can you tell me about Steve? Can we go see Steve together? So ideally they're aware, because there's ideally like warm handoffs happening and joint outreach. That's again not the same for like a clinic necessarily, but for the teams that are working in the fields, like the case manager should know, because ideally we're going together to like meet the person for the first time.
Right. For the first time you go with them to meet them, but after that you may go out on your own.
After that, we
They
often
wouldn't
have to
know
go
about
out on
that?
our own, because at that point it is a health service. So like as an analogy, I can't forcibly accompany you to your primary care provider's office, right? Like these are the laws that we have to follow. So it's a health service being provided. It cannot be provided with people often outside the program.
But to be clear, then, a case manager that submits a referral will know whether or not, they got to the right person, because the expectation on DMH's side is that you're reaching out to the referring party to, get additional information, do a warm handoff of sorts, provide additional context. So
For home, when it is a home or FSP case, yes, absolutely.
Okay, so when it's
If it
home or
goes-
FSP,
Yeah,
not
if it goes to a
necessarily.
clinic or some of the other programs, that may not be possible. Yeah.
Okay.
Yeah.
Thank you for that clarification.
Hey,
Norma, I see
Norma,
your hand
over
is
to you.
Hi everyone, thank you Dan for that clarification. I had another follow-up question. So I know you have privacy laws you have to follow. There's been instances where my team and I we work with the Torrance Outreach team, and we've accompanied our clients to their DMH clinic appointments. Literally like sat in the office with them because they gave us their consent, and we signed that release of information. Are we able to do that with the different teams that
course.
you guys have? And then
Yeah,
maybe
of
are
course.
we able
Yeah,
to case conference?
of course, if a client gives consent, absolutely. If a client is asking for your involvement in treatment, we are never going to turn that away. It's the like without a client, about a client stuff that cannot happen. But of course, clients can give consent for information sharing.
Okay, great. Thank you. And then additionally, let's say a client is in FSP, and my understanding, because I referred people to the FSP program before, if they decline, right, of services, you eventually have to close that referral because they're not open to that service. Um, if they go to the next, level of care, next team, and let's say something's not working with that team either, at that point, are you guys, let's say, can home team do care referrals, or would it be the other way around?
It's the other way around. So care refers to us. We are the top of it. FSP, AOT care refer to us when necessary. They should. I am not going to tell you that we are a perfect system, right? Like no system of people is perfect. And so though that should happen, it does not always happen. And again, that's you have a tracking number. And so if you don't feel like it's being followed up on, you might not be able to get the information you want when you call, but you can, or email, but you can say, like, if this isn't linked, I'm hoping that it can get to the higher level of care. Yes, the consent form is available on the DMH website.
Okay, got it. And then another last question. After how many, do you have like I know, obviously it takes time to build rapport with people. We see that in our work all the time, but do you know, let's say after how many attempts or a certain time frame when let's say someone is still refusing services, clearly they're showing signs of, psychosis, or, you know, their severe mental illness is preventing them from accessing housing and other resources. Let's say maybe they are able to care for themselves and using the restroom, eating, but they're still choosing to be in the same spot every day, all day, when they could be indoors. They're, let's say they're someone who's elderly. After what point are you guys determining to hospitalize someone?
I really can't answer that question. There's no formula. There's no line. There is clinical judgment by trained, licensed mental health providers, and so a lot goes into every one of those decisions. And again, there is always an attempt to ensure that every less restrictive level of care, every less restrictive intervention has been tried. So there's no like number of days after which we would hospitalize somebody. And it also varies based on what somebody's capacity is assessed to be, right? So we might think that somebody is making bad decisions, but if in a true mental health assessment, we determine that person has the ability to make decisions, we may not be able to pursue hospitalization in that case. In other cases where somebody is out there because they think if something like if they go inside, God will kill everybody that they love, something like that, right? That is a reason that we would need to hospitalize somebody. But people do have the right to choose to be homeless.
Thank you.
Yeah.
Seeing no more questions, Dan and Andre, I want to say thank you very much for
I
the
had a quick
presentation.
question.
Oh,
Sorry,
okay.
Bill.
Addie, over to you.
Yeah. Oh, thanks, Bill. So just a quick question. I know, Dan, you spoke briefly about how, you know, in the process or the referral process, you can be like, this is a blue shirt by this bench, by this in this area, etc. How would you encourage, or how would you go about referring someone who maybe the case managers or outreach team don't have names
Yeah.
for, and
So
be service
hopefully,
resistant?
yeah. Hopefully there's an HMIS number in those cases that has been created for somebody, if it's an outreach team that has access to HMIS. If not, as much detail as you possibly can provide, and contact information so that the team can coordinate with you, right? Again, so that, like as Audrey was describing earlier, like that initial contact, we would go out with you, you'd point them out to the FSP or to care, AOT, or home, right? Those initial efforts would be with the person who knows the referred party.
But if they have no name at all, so I'm just thinking there's a city, there's an example that I in my head know. There's a city where there's an individual that is in a parking lot, has been there for 3 years, seemingly struggles with some pretty severe mental health challenges, but hasn't spoken to anyone in 2 years, so they have no name for him,
Yeah.
and thus no HMIS ID. How would
I
we
would
referring or?
generally, people like that have HMIS IDs with a name based on their location. I would hope that they do, because and that gets shared with everybody in the area. If not, and I think that's rare, but if not, just whatever you got, John Doe, or make up a name. But as long as there's enough information shared on the rest of the referral for us to be able to coordinate with somebody to point this person out or go out the first time, right? Whatever would be necessary, as much as you have.
Okay, thank you. So in conclusion, the referral portal is where folks should start. Give as much information and detail as possible. From that referral portal, it'll get sent over to your team. Based on that information, your team decides what level of care or what partners will be outreaching them.
Doesn't
And
get
then,
sent to our team for that, to a triage team in the department, and then could get sent to our team after that. Yes, we are one of the levels of care.
the highest level of care for home team.
Yep.
Okay. Sounds good. Thank you so much, Dan and Aubrey, and the rest of DMH that is on this call. We really do appreciate you all making the time to be here and walk us through these resources. For those who have asked me privately, I do believe we'll be receiving this slide deck, and so I will send it out with a follow-up email for additional meeting materials.
Yeah, and I just got one more comment. I'm on the LA District Attorney's Homeless Advisory Board. And, we've had a lot of discussion how, what can the LA District Attorney do to make sure that, people that need mental health resources, if you will, get them into those, get them into the program where appropriate, right? So, Dan, Aubrey, I'll probably reach out to you just for subsequent conversations on, what you think those opportunities may be.
And they are welcome to use the universal entry referral as well. I've really used it at this point.
Very good. Appreciate it. Okay. Moving on. I really appreciate that. Okay. Next one, presentation on Emergency Centralized Response Center. Donald Holt, Principal Analyst, are you on?
Yes, I'm here. How's it going, Bill?
Good. Over to you, sir.
Okay. Thanks for asking. If you don't mind, I'll share my screen and I'll get started. Good evening, everyone.
Good evening, welcome. I hate people having silence when they say good evening.
Are you all able to see my screen?
Not yet.
Okay, one
Good
second.
afternoon, by the way.
Oh,
Not quite there yet. Um, you, Addie, over to you. Oh, here we
okay.
go. Looks like it's coming up.
All right. Are you able to see my screen here?
You're up.
All right. Well, thank you all. Thanks for having me. Good evening. My name is Donald Holt. I'm the principal analyst here at the Emergency Centralized Response Center for the County of Los Angeles Chief Executive Office Homeless Initiative. And so the ECRC functions. We triage calls and emails from elected officials and government agencies regarding encampments and people experiencing homelessness. We coordinate outreach efforts throughout the county with a wide range of agencies serving people who are unsheltered. We respond to emergencies that impact unsheltered populations, so that includes fires, heat waves, extreme cold weather, whatever natural disasters may occur, earthquakes. Support with access to interim housing and other county resources. So this is our ECRC staffing. Our staffing consists of 8 staff that cover all 8 spas. So we have teams of 2. We have senior analysts and we have analysts. Each one of those analysts are assigned to spas. So we have analysts and a senior analyst assigned to spa 1 and 2, assigned to spa 3 and 7, assigned to spa 6 and 8, and assigned to spa 4 and 5. So for you all would be primarily working with Josh Steinberger and Byron Vargas, who are in this meeting. Josh is our senior analyst and Byron is our analyst. I will be sure to share their contact information with Addie so she can share it out with the group. In addition to our staff, we do have two additional staff that work with our host operations. And so our host operations are when we identify locations for a cleanup, whether it's a full displacement or non-displacement, we do coordinate with DPW, and we also coordinate with the Sheriff's Department. During the planning for those operations, we do deploy outreach teams, engage people that are experiencing homelessness in hopes of bringing as many people indoors and linking them to other housing services prior to the operation occurring. And so in addition to our staff that are housed here at the Hall of Records, we also have our ECRC partners that are actually staffed in the same location with us. That consists of DMH, so you all were able to meet the lovely Aubrey and her team, DHS, LASA, MVA, which is Military and Veteran Affairs, the Sheriff's Department, Department of Social Services, and SAPC, Los Angeles County Substance Abuse Prevention and Control. So unsheltered services, we link individuals to emergency shelter, interim housing, problem solving, time-limited subsidies, physical and mental health services, substance abuse services, legal, military, and financial benefits. And we also oversee all of the outreach coordination throughout LA County, including LA HOP. I just want to make sure that I do point this out and highlight this. ECRC does not have a special pot of beds. We don't have any additional beds outside of the beds that exist in the system. Based on how we're set up and having all of our partners share one office space, we are able to problem solve fairly quickly because all of our partners are actually physically here with us. So it eliminates the need for us to send emails, text messages, make phone calls. So in most cases, we're able to eliminate barriers or problem solve and make sure that we get individuals experiencing homelessness linked to those services. So outreach partnership, ECRC deploys outreach teams as mentioned through our ECRC requests that comes from elected offices directly to us. And again, we now oversee LA HOP. So any requests that are put into LA HOP, ECRC is responsible for dispatching those teams based on the request that we receive. We connect outreach teams, linkages, we connect our outreach teams to our ECRC partners that I just mentioned. And reporting, Outreach teams will provide updates to ECRC. We will in turn provide updates to elected offices, business owners, and constituents on outreach efforts and outcomes. ECRC and outreach will assist in securing interim housing for PEH during coordinated efforts. So again, as mentioned, during those operations and just in every day, we are available to assist outreach teams with linking individuals to those housing services. So ECRC has been around since December, and so we're approaching our 9-month mark. These are just a few notable projects that we've been a part of. In the city of Industry, there were 20 to 40 people experiencing homelessness on private property in trailers. And some of you may be aware of Baluna Creek, which is a large area and has had an ongoing issue with people experiencing homelessness occupying that location. That concludes my presentation. It's short, sweet. I am open for questions. So please feel free. Yes, Rick?
Don, LAHSA just announced October layoffs of a lot of their outreach workers. And now I have no idea what's going to replace that. I'm sure I'm not the only one who knows this. What do you think it's going to mean?
Yeah, and so Rick, my apologies. I cannot speak for LAHSA or that process right now. It's still actually in progress of finding out exactly what that means and what that entails. And so I do not want to speak prematurely about that and provide any erroneous information.
No, I wasn't asking about that. I was asking whether you think you had the resources to pick up the slack,
I mean, we work with the existing outreach teams, which includes those LAHSA teams that you're referring to. And so I will say that there is going to be a need to have those outreach staff continue to operate. Again, I don't know in what capacity. So if all of those positions were eliminated, hypothetically speaking, I'm certain that it would be problematic. But again, I'm reluctant to speak to that because I don't want to provide any erroneous information. But we do need that capacity. We do need that manpower. Absolutely. Any other questions? Hey, Grace, how's it going? It's been a long time.
Nice to see you.
Good to see you as well.
Okay, are there other questions? I don't see any other hands up.
I had a quick question. And thank you, Donald, for again being here, making the time to provide some more information on a lot of the fast-moving changes that we're experiencing here at the start of the new fiscal year. So could you maybe, for those that are less familiar, some of the people on this call have seen this before or know some of this information, but for folks that are a little bit less familiar, can you maybe give us a brief explanation of how you all are leveraging existing outreach teams to, I think, address the referrals or complete the referrals that you all are getting through LA Hop, and then maybe also just the chain of escalation, if that even does exist, right? Like a lot of the times the referrals that the teams are sending you or that elected officials or community members are sending are already individuals that have been outreached by those local outreach teams. So what happens after that, right? Like if the city of, well, Bill's here, but the city of Alameda sends in a request for this person that their outreach team has already outreached, does it go to them? And then does it go anywhere else if the person isn't responsive to this outreach team? If that makes sense?
Yeah, so in LA Hop, there is a caveat to LA Hop. So for example, in that particular situation, if the team has made contact and they've built rapport and that individual has not been placed into interim housing, then we would not close that LA Hop ticket. We will continue to deploy outreach to engage that individual until we're able to bring them indoors. Unfortunately, if the outreach team goes out 2 times and they attempt to engage the individual and are unable to locate that person, then the ticket would be closed in LA Hop based on unable to locate. But if that ticket is then again put into LA Hop for the same individual, let's say within an hour after it being closed, we will then deploy a team once again. But yeah, the ticket won't be closed unless we're unable to locate the individual or that individual has been placed into interim housing or we've resolved their homeless issue through other means like reunification with family or other linkages to housing services.
Okay, so the first line of service would be the existing outreach team local to that area. And then say if they're not interested in engaging or interfacing with that outreach team, a separate team can go out or a different resource?
Well, we would like to have the same team go out in an effort to
Okay.
build rapport. You don't want to have different teams. We're in the people business, and so you want to definitely, again, unless there's something that took place during the initial engagement that warrants us to send another team. Outside of that, we would love and encourage the same team to continue to engage that individual or individuals at that location in hopes that they can build rapport and establish some trust so that they may be interested in coming indoors.
Okay. I just asked because sometimes I know like I meet with a variety of our case managers in the area, and so they'll be like, as soon as they see my shirt with my company logo or my city logo, they'll like run for the hills, right? So while they may not be interested in engaging with the team that they're most familiar with, sometimes there's success when they engage with different teams. So
Oh
I
yeah.
guess trying to figure out if at any point we are like, okay, if they don't want to, you know, if they don't want to engage with Addy United, they'll go
Oh,
and do different
absolutely. If
things.
we receive information from you, or anywhere, I mean, because realize LA Hop is also available to people experiencing homelessness. So they can very well put in a ticket or a request and say, I don't want Addie's team to engage me any longer. And of course, we would deploy another team. Now, also, if we identify an individual that has, a mental health need or a physical health need, then we would deploy the appropriate entities, DMH, a multidisciplinary team, where they're able to go out and address their physical needs. And if it's a veteran, we would work with a team that has, a veteran outreach team. And so, absolutely, if there is a reason and that person does not want to engage, we would absolutely look for another team in that area and have them to engage.
Okay.
Yeah, the goal is to build rapport and hopefully to bring them indoors and link them to services as soon as possible.
Okay. And then last question for me will be, I know that you said that you all don't have a different, special fund or pot of beds. So my understanding is that you're just leveraging the existing resources by community or by SPA or however it is that it's broken up on the back end.
Correct. Correct.
Okay.
Yeah. So we do receive a list of availability from DMH based on SPA and also from Housing for Health. And then based on that availability, we get that every day, every morning. We try to link individuals to those housing opportunities that are in those, well, within the county. But first and foremost, most people would like to remain in the area that they're in. And so we like to identify beds in that particular space. And not displace them to another spa if we don't have to. But if they're open or they request to go to another spa, then we can make that happen as well. But traditionally, people like to remain in the area that they are residing in.
Thank you so much. That answers my questions. I will
More than welcome. More than welcome. Okay. I don't know if Lori or Grace had their hand up first.
They do.
I think it was
Grace,
me.
over to you.
Yeah. So my question was really related to what Rick was saying. With the changes that has happened recently with LASA, with outreach teams, is there a way for HI or for you all to check what kind of messaging we can give folks? Because they're going to ask, and I think people's natural inclination will be, well, we're going to call the county for outreach staff or help. Obviously there's going to be a transition, and sometimes that's not communicated to everybody. So is that something you can have someone look into?
I can definitely, Grace, follow up on that and get back to you
Okay.
and figure out what that messaging could be. So it's not something I'm able to provide to you right now, but I will absolutely do my due diligence and get back to you.
All right. Thank you.
Oh, more than welcome.
Hey, Lori, over to you.
Okay, thank you. This is Lori from METLA, the MDT teams.
Hi, Lori.
Addie, I wanted, not really a question for you, Donald, it's just to kind of piggyback off something you said. Addie, you were bringing up about how sometimes they might not want to work with a particular team, or maybe something happens with that relationship. And I was just going to say, between outreach teams, we can pull in other people. And a lot of times, like LASA will reach out to the MDT and say, hey, there's a lot of mental health stuff going on. Can you guys assist? And we'll work together. If we can piggyback off that relationship, we will. But if, there's a break in that relationship, then we might take over. So there is a process where another team can take over if that's what's necessary. It doesn't necessarily have to go through the HOP, the LA HOP. but the teams reach out to each other, the outreach workers reach out to each other, and we do that all the time. So I just wanted to address that.
Thank you for that, Laura. And I would just like to mention, oftentimes we do receive requests for locations that are multi-jurisdictional. And so when that happens, we are the entity that brings all of those other agencies into one space to ensure that we're all operating on one accord. So for example, I mentioned Baluna Creek. Some of you may be familiar with Whittier Narrows, places like that. It's multi-jurisdictional. There's a lot of different agencies or entities that have jurisdiction over certain parts of Whittier Narrows or Baluna Creek. And so we are the entity that brings everyone together, make sure that we plan an effort that everybody's aligned with to ensure that individuals don't just move from one jurisdiction to another. So I'm sure, again, as some of you are very familiar with, people experiencing homelessness are extremely smart and they know those jurisdictional boundaries. And so you may be having an operation in the city of LA, and 2 blocks up, it may be the city, Culver City, for example, and they will just simply move to Culver City with the understanding that LAPD doesn't have jurisdiction over there. And once the cleanup and operation is done, they just move back across the street. So we're instrumental in making sure that we limit that. And yeah, that's another space that we occupy, is to bring all those entities together and make sure we're operating on one accord. Any other questions? And I will share my email in the chat, and I will also share Josh and Byron's email with you all. Feel free to reach out and look forward to collaborating with you all. Good to see you again, Addie.
And thank you. And then any plans to take over 211 at any point in the future down the line, or 211, I guess you all would say, but in my mind, it's 211.
Not to my knowledge.
Okay.
We did have a meeting with 211 last week, and so we are working collaboratively with them. As you all know, it has been a huge struggle with families. The family system has been completely inundated. And so having a meeting with 211 to kind of figure out how we could provide more assistance while, there is a shortage in family resources, it's been extremely challenging on that front. So no plans to take it over to my knowledge, and that's possibly far above my pay grade, Addie. But I can't say that we are working with them collaboratively. Yeah.
Amazing. Okay, thank you. When I initially heard of basically the efforts to centralize or coordinate all of our resources, 211 is something that does something obviously similarly for the region. So in my mind, it would make sense to combine them, but that is also above my pay grade. So I won't worry myself with those things anymore. Thank you so much for being here, Donald, and for your team as well. And if you all haven't noticed, his team, Josh and Byron, dropped their emails in the chat, and I will send it up with the follow-up materials.
All right,
Thank
wonderful.
you so much.
Well, thank you all.
Yep. Thank you very much, Donald. Appreciate it. Okay, so moving on, is Ronson back with us?
Ronson is still on his La Casa meeting. And for those of you all that missed it, I know he gave a super brief update at the beginning of this meeting. La Casa is happening concurrently. And so he's attending that meeting for, updates. And the only update that we have on our end is that the La Casa policy guidelines and expenditure plan for the technical assistance piece has been approved. So we're going to be able to start our technical assistance piece in the South Bay. However, the other two buckets or items haven't been approved. And so he's in that meeting right now. So we should have updates after likely like 5 or 6 p.m. But nothing more than the TA, the technical assistance, has been approved for us at the South Bay COG. And across the board. So that's it on La Casa updates.
Okay, thank you. So moving on to legislative updates. Anyone on to give a legislative update?
Yeah, anyone from our local representatives? I saw Moises and Janet on. I don't know if either of them have updates for us.
I mean, obviously, I know there's a lot going on in Sacramento, and they're still making the sausage and whatnot.
I saw Janet unmute herself, I think.
Good morning. I don't my crazy computer. I don't know if you can hear me.
Yep, we can hear you, Janet. You're up.
Congress is in recess right now and won't be back until September. So nothing new to report. They're saying that they're going to be super busy when they go back. So hopefully I'll have lots to tell you about in September. And thank you for all the wonderful presentations you put together. Very, very helpful. Really appreciate all the hard work and all the good information. Thanks so much.
Okay, thank you, Janet. Okay. Eddie, anybody else? We good? Okay.
I only see those two offices on right now. So if they don't have
Okay.
anything to...
Moving on. Jackie, South Bay City's Council of Governments update?
We've moved, and you can see our new building behind us. We're going to have an open house in November. But in the meantime, Addie and I are sagging under the weight of trying to hire people for Measure A. And we're so at our next meeting, I'm sure we'll be able to introduce you to some new staff. We're getting ready for the programs and the policies. It's taking up a lot of time. We have several other projects that we're working on, a housing trust, for example, that will be coming to the board probably in October. But there's nothing really specific. Oh, I guess I could say, well, I couldn't. I will wait till our board meeting. I'm not going to say that.
Don't get ahead of yourself, Jackie.
Yeah, our General Assembly is going to be on March 26th, so save the date. And I don't think there's much else that I should share, but so thank you.
Okay, very good. So moving on, number 8, LA County CEO Homeless Initiative update. Is Clifton on?
I think Clifton is skipping today since we had a pretty big update at the beginning, shared by Grace and Ryan. So I don't know if there's any pertinent updates this time around.
See, we're ahead of schedule.
That's what I like to see.
Okay, any announcements?
Yeah, Shannon, I don't know if you'd like to share or
Wait, I see Janet waving her hand.
I just wanted to mention I tried to download Dan Mansfield's slides and they failed. So I presume you'll send them out on your own for us.
Yeah, Addie, you'll be sending all the slides out and contact information, et cetera, right?
Yes, I'll get those for you, Janet.
Thank you so much.
You're welcome.
Okay. Oh, Madeline, you have your hand up?
Yes, I just wanted to share, I don't know if anyone on if this is relevant for anyone on the call, but on Monday we have our service fair for our homeless clients. So the last Monday of the month, every Monday we have showers and Venice Clinic and haircuts. But on the last Monday of the month, Better Angels comes in and they provide a bunch of other services and DPSS and tap cards and like all kinds of groups come in. So if you have any participants that might be in the area on Monday, feel free to send them by. Starting at 9, goes until about like 2, and we'll have a hot lunch at 11:30.
Great, thank you. Okay, Grace, you have your hand up?
Yeah, just to let everybody know, the next South Bay Coalition to End Homelessness meeting will be on Wednesday, September 24th. We'll be sending out a notice, but just wanted to let everybody know that's usually from 1:30 to 3, and it will be virtual.
Okay. So I think that's it. Addie, anything else? Keep me honest. No?
No, I think that's it. We have made it through ahead of schedule, so we will return likely 26 minutes of your time back. I hope you use them wisely.
Oh, wait,
no,
Jackie's
Jackie.
waving her arm. One second, over to you, Jackie.
I continually forget this. Isn't our next meeting going to be like either in person or hybrid?
Well, so the next one,
that.
the coalition will be doing. They just said it's virtual, but the next meeting we host, if you'd like to do it hybrid, we can do
we
that.
said that. I think
Okay,
we
so
were going to
let's
do
do
the
it.
next meeting hybrid. Okay. Sorry, I always
So-
forget that. Thank you.
So October will likely be hybrid,
Okay,
So
so people have an opportunity to attend in person and or Zoom, right?
Right.
yes, for our October
October 15th.
October meeting. Jeez.
October 15th. So look for that information when Addie sends it out. So with
Yes.
that, appreciate everybody. Have a wonderful day. It's 4:34 and we are adjourned.
Thank you, Bill.
Thanks,
Yeah, what do you
everybody.
want? Thank you, everybody. Thank you.
Everyone.
Good job, Addie.
Thanks, Kathy.
Hi, I'm awake still. I
Oh
made
my
it.
gosh, it's so late for you there, right?
It's 7:34.
Oh my gosh, get some sleep.
Go to
Hey,
sleep, Kathy.
yeah, no, I just kind of I make it. You know, I kind of stagger this day. It was a slow day, so I could get through. Okay.
Yay. Go ahead. Take a 14-hour nap, as I like to call it. Just go ahead.
Yeah, like you
Like a
should
little.
do the same thing.
I wish. I wish. I'm gonna try my best.
You need to slow it down for a minute, girl.
I know,
I
I
don't
know.
want you sick. I don't want you getting sick.
I know, girl. I'm trying. I'm trying my best. It's just so much to do, so little time.
I know.
But okay. Oh,
Hey, Ronson canceled our meeting tomorrow. We don't have to talk.